Welcome to the Waiting Room Revolution. On today's episode, we are talking with Elise Maybee and Amy Ma. Elise is a co-founder and chair of the Patients Advisory Network, or PAN, and a patient partner in various research projects. And Amy Ma is also a co-founder of PAN, as well as a Choosing Wisely Canada's patient and public advisor. We talk about their experiences with healthcare, their reactions to the 7 keys in the waiting room revolution, and why we need to change medicine to be delivered on the patient's terms. Hi, I'm Hsien Xiao.
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The waiting room revolution starts right now. Elise, Amy, welcome to the podcast.
Thank you.
Thank you for having us.
I'd love to hear a little bit about why you founded PAN, which is the Patient Advisors Network, and your story behind it, why you were so passionate about it.
Well, thanks for asking about that. The Patient Advisors Network, or PAN, came about because those of us who are patient partners, in a bunch of us in downtown Toronto had been to an event, and we went to coffee and we shared our experiences and we were learning from each other, and we thought, wow, this is so great. Let's see if there's any organization of like-minded people who are also patient partners, or patient and family advisors, as we were called in those days. And we searched, found nothing. So we thought, oh, okay, so I guess we're going to have to create it. And that was the germ or the genesis of PAN. Then subsequently, shortly after that, two of us were going to be going to a conference in Vancouver. And one of us was not me, was very good in Twitter. And she got in touch with the patient partner community in Twitter and asked, who was going to go to this thing and could we meet up and so on. So we very intentionally had a dinner with a bunch of people from all across Canada, mostly, on some from the US as well, and floated the idea there. I stayed for a week after and actually made appointments to talk to a bunch of different patient and family advisors. And that's how I came to know Carolyn Canfield, whom I think maybe a bunch of you know. And the two of us met for lunch and stayed through dinner. Mm-hmm. And so then when I returned back home here, we just created an organization, and we pulled together 12 of our colleagues from across Canada. We felt very much that if you were going to be Canadian, you had to start across the country. You couldn't start in Toronto. You'd never get out of it. So we did that. We had 12 people. Amy was one of them. And we took about 9 months to birth our manifesto, which was really who are we, what are we about, and so on. And then we launched our website in 2017, and with all volunteers and no marketing money, we just let word of mouth build our community. And that's what we did and why we did it and where we are.
I have a question. You hear so many terms like patient advisor or patient partner or patient advocate. People tend to use them synonymously, but what is the term we should be using, or are they all different?
There are variations on a theme, I would say. I'll have a crack at it, and maybe Amy can fill out my blanks, if you will. But we used to be called patient advisors or patient and family advisors in the early days of patient engagement, when patient engagement was really just listening to us, maybe taking what we said. But patient engagement has matured over the years so that we now actually partner. So we co-design, we co-decide, we do much more substantive work with our healthcare colleagues. And so the preferred term is patient partners, with the understanding that includes caregivers. In terms of patient advocates are slightly different. They're often people who have a particular issue, a usually single issue that they want to see handled in particular ways. They do amazing work, but they're somewhat different in that they are more of a lobbyist, if you will. When you think of the blood scandal, for instance, that came, the addressing of that came about in large measure because of the amazing work that the HIV community had, in particular, as patient advocates. The work that we do as patient partners tends to be collaborative and working collegially on projects with members of the healthcare community.
I would have to say that there might be some overlap because, certainly in the States, they have, I would hesitate to use the word industry, but an industry of patient advocates because of the way that their healthcare system is structured versus insurance and all that stuff. And there's also people that hang a shingle out on LinkedIn calling themselves patient advocates because they have a background in nursing or in social work, and they help people to navigate through, say, placing an elderly family member in a long-term care home or whatever. So it can be a bit unclear when titles are being thrown about and there isn't any consistency. So you really have to look at the context of what organization or what that person's background is. And getting back to my earlier comment about where there's an overlap, I myself sometimes use the word patient advocate, if only because in Quebec, we have this system of patient committees for every single hospital and resident committees for every single government-funded long-term care home. And they rose about because of a human rights issue of the abuse encountered by residents that were institutionalized back in the day. So, and probably with the HIV blood scandal too, there's a certain component of your lived experience that comes into play, whether you use advocate or you use partner. And like Elise said, advocate is more like a winner takes all lobbying for a certain position. And some people can wear both hats, and some people feel more comfortable with just the co-design and not necessarily for a rights-based type of approach or an advocacy lens. And other people only want to do the advocacy work. And then there are some people that have worn both hats alternately.
Thank you for that. That's very helpful. I provide palliative care in people's homes, and I often refer to the family, or in quotations, or as my partners in care. And it just strikes me that when I read about patients and family co-designing or being at the tables or being partners in such and such, I feel like we give less spotlight to patients and families actually literally being partners in their healthcare on a day-to-day, in the trenches, practical way. There's also different layers that these folks can be involved. But like I said, I feel like we know less about how to literally partner in their care while they journey through a progressive life-limiting illness, and that people are invited to tables after the fact when they've had a terrible experience personally.
Yeah, I think there's a lot of moving parts. I think the way medical education is taught, it comes from a hierarchical system that was never designed to accommodate women, that was never designed to accommodate racialized minorities, that was never designed certainly to accommodate people with disability.
Mm-hmm.
And then I think I've seen it best when someone said, you should think of patients, families, and caregivers adding you, the clinician, on to their care team instead of us being an appendage after the fact. Things are slowly changing. It's not even. There are probably some pockets, even within a given institution, that are more progressive than others.
Mm-hmm.
If I would take a step back, like it sounds like both of you have had healthcare experiences that have led you to be passionate about the importance of a patient partner or a family partner. So I'm just curious if you're willing to share just a little bit about what that experience has been that was the catalyst for, recognizing why this is so important.
Okay, so I think of two stories. I think of my mom, newly arrived immigrant, and I was her firstborn a couple of years later. And that was back in the 70s when people weren't throwing the doors open for men to be by their partner's side when they were giving birth. And so my dad wasn't there. And my mom told me this, of course, years later after the fact, but here she is, totally unfamiliar healthcare system, doesn't necessarily have a strong network of people that have been there ahead of her to tell her something very basic, such as you can actually decline to be the guinea pig on display if you want to. And my mother was a very reserved person, and you never get to redo giving birth to your firstborn. And I think it was terrible for her, someone who's very reserved and shy, to have 20 people that she doesn't know and no support person of her choice by her side for such a pivotal moment in her life. So there's that. And then also, as I mentioned earlier, I have 3 children, one of whom had 2 surgeries before the age of 2. So on the one hand, public health messaging says, breastfeed your baby, breastfeed your baby. And my 4-month-old goes in for surgery, and lo and behold, I'm his food source. He's 100% breastfed. And the hospital gives me the pump that I need to feel comfortable for the duration that he's under surgery. And we have to stay at least one day, one night for observation, but I'm not being fed. If my child was formula fed, that would be on the hospital's tab. So I just find it that it's disjointed. There's a funding gap and there's a silo somewhere that doesn't recognize me as a key part of my baby, that I had to scramble and go across the street to a grocery store and find frozen entrees to put in the staff fridge. So there you go.
And how about you, Elise?
So my experience is mostly I have been the subject of accidents. I was crushed in a car accident at the age of 22, followed by smashing my elbow and needing it replaced. And then a year and a bit ago, I broke my ankle. Running down the up escalator, I might add. So all on me. But my really pivotal experiences have been with the death of my father, the death of my stepfather, and the death of my mother. And they were actually, if you can call the loss of someone you love positive, they were actually very positive experiences. So when I was 9 years old, my father was diagnosed with acute leukemia and given 3 months to live. And thank goodness my mother was Dutch, because the Dutch tend to face things straight on. And so she told me and my sister right away that this was happening in our lives and that we would have to change how we thought and how we lived, and that there would be more expected of us. So we became the first latchkey kids that we knew. And yeah, but it also meant that even as a child, I understood my time with my father was limited. So when I came home from school, the first thing I did was go upstairs and sit on his bed and tell him all about my day. And he was wonderful. I think he understood too that his time with me was limited. He did. And so he gave me 100% of his time. I had so much more of a father than any of my friends did because of that. So that was very positive. And a lot of it was because nobody lied to us and we knew what was happening. And, you know, anyway, I could go on about that, but that was really a gift. I had such a gift of my father because nobody lied to us. And yeah, so that's the story of my father. My stepfather, because my mother went back to the Netherlands after he died and remarried her childhood sweetheart. He was quite an interesting man. He was a physician and they were married for more than 40 years. And when I came, well, he was a physician and he was in his late 80s when he was diagnosed with abdominal cancer. So he underwent treatment for it. He was diagnosed in the fall, treatment through the winter. In my visit in March, we're sitting there balancing our teacups talking, and he says to me, "So I'm dying and we need to talk. Just like, please pass the cookies," right? Typical Dutch. And so we did. And we talked about, you know, what his prognosis was, the fact that he decided no more treatment because it was terminal and this was his exit. And he was quite comfortable with that. But his biggest concern was for my mother, who was in a dementia facility at that time, and how would that be handled? And so we had the gift of being able to really plan out what was going to be for my mother, and put his mind at rest before he passed. My mother, on the other hand, she was diagnosed with dementia at 80, and she lived in the Netherlands with my stepfather. She was cared for by him. He was a retired physician, so he was able to do that. And then one day he had to go to hospital for an emergency operation, and she could not be left alone. So I had to fly over and be with her, which I was. It was very clear he couldn't continue. So I had to find a dementia facility for her in the Netherlands, which took learning the Dutch healthcare system, figuring it all out. But her primary care doctor was an enormous help. And he hooked me up with all the things I needed to do, the evaluations that needed to happen, and the different options I had, and so on. So I did all the due diligence, put myself on a waiting list, or put her on a waiting list. And fortunately, while I was there, they were able to place her, and we could do that.
It's interesting because normally people talk about, oh yeah, those 7 keys resonate with us because those all went wrong in our story. But in your situation, 3 times over, they resonate with you because that's what made the experience go as good as it could go. And you were 3 times lucky, I guess I would say. Maybe we need to channel our inner Dutch people.
Well, in this culture, we don't like to talk about death. We don't like to face it. We avoid it. And there's a lot to be said for actually being upfront about it, to understand, what might go on, and so on. And certainly because I'm in my 70s now, I'm actually planning for those things. I'm purging my stuff. I'm getting my will in order, all of those things, because I want to make it easy for my family and easy to make decisions.
Amy, maybe I can ask you, like, if what have you thought about our podcast, and did they resonate with you as with your own healthcare experiences?
Well, I did accompany my mom as well as I could from afar. She ultimately died from colon cancer about 16 years ago. And I think between my father and my 2 brothers, it resonated with me that it doesn't necessarily have to be the person who has the illness themselves, but as long as somebody amongst the immediate close family is willing to keep track and have the bird's eye view of where things are going, and not be just so tucked into the minutiae of everything, that it helps to move away forward. And that was my first contact with palliative care. And I think they're a special breed of people, because I was in my early 30s with a young 2-year-old. And so I had to grieve, and I also had to still be a parent and a spouse. And that wasn't something that very many of the people in my peer group had to deal with.
In many ways, our podcast, we both have expertise in palliative care, but Patient Advisory Network is not advisors network is not specific to palliative care and serious illness. It can be for any kind of research project and very broad. And so I wondered if you felt like these keys and even our mission to empower patients and families is beyond just palliative care. If there's a connection here to other kinds of chronic disease or other health challenges.
I think so, if I can just jump in, because I think the point about there being a journey and that it could be understood and managed is one that applies to sort of any chronic disease, from what I understand, not having one myself. So maybe I'm speaking out of turn. But even when I look at my own sort of, if you will, health journeys, which are very episodal and related usually to doing some critical damage to myself, there is a journey, there is a route, and it is understood and known. And the last experience I had with breaking my ankle and having an operation on it 2 years ago, there, I knew the sort of mechanical part of the journey. Yeah, I was going to go in. Yes, they were going to, do an operation and, put plates and screws, all of which they did. And I knew that it would take, X time for the bones to heal and that I'd be in a boot for a period of time. But there was nothing really else around that much to tell me sort of what to expect. Or even how to manage my caregiver husband who was
Mhm.
finding it difficult,
Yeah,
So
for sure. Like, how do you how do you take a shower now and go to the washroom, or all these kinds of everyday tasks? Yeah.
yeah, I mean, we did have an OT who came in, but basically we had to do a lot of that research beforehand, just to understand it and get what equipment we needed, because I needed a shower stool and a raised toilet seat and all of those other kinds of things, which I would never have guessed when I was first lying in hospital with a broken ankle.
Mhm.
Um,
I guess the 7 keys are an ultimate goal that you would want anyone and everyone to get to, regardless of their postal code, regardless of their socioeconomic status, regardless of whether they're disabled or not. It's just that there's so many barriers put in place if you're rural or remote, for instance. There was a number of workshops our hospital hosted on Indigenous health and culture. And the fact that some people actually have to end up doing palliative care in a hotel not far from a regional hospital, it just kind of breaks my heart that the quality isn't there for a nation like Canada that is supposedly wealthy enough to do better, but isn't, and is failing on multiple levels, especially for Indigenous people in particular, that it's not dignified for some people, especially the Indigenous people to whom land is such a strong connection, that they are deprived of that very key essential thing of their being, of their spirituality, right at a point of transition when it matters most, that they're moving on in their journey to the next life.
hmm.
Yeah, I think it's something we really do need to be sensitive to, is different populations of people have different relationships with the healthcare system. And it's not so easy to say, well, you need to step up and speak up and come forward and, be empowered, because people come with a whole history. Uh, so, yeah, that's something for us to think about.
And if I can just pick up on Amy's point, because as I said, I'm, if you will, bicultural, and the Dutch deal with death straight on. There are a lot of cultures that do, and there are a lot of cultures that don't. And there are a lot of cultures, as Amy pointed out, the Indigenous in particular, that have particular practices or spiritual needs around the whole process of death that are different from, if you will, the mainstream or whatever. And accommodating that's quite the challenge, but I think also necessary for all of those reasons that Amy was saying.
Mhm, mhm, mhm.
Which is why I think invite yourself, our 7 key, is so important, because we should not presume that we have a solution or there's one size fits all, right? Asking people, what is their understanding? What are their needs? How can we customize this for you? By inviting them in and doing that repeatedly, as Sammy has taught me, is the key, because it allows you to continually gain information and adjust to what is important to the people. But we should not assume we know, or that they want to die at home, or that they want to be flown to a hospital to get the best care. That may not be what they want. And I think we should stop and ask.
Yeah, I mean, Hsien and I talk in one episode of the podcast series about the healthcare system being like a conveyor belt, right? And conveyor belts are meant for mass production, to replicate things over and over, a sameness, a standard, right? But I guess that's the tension here, is because what we're trying to say is that, okay, there's something to be said for having standards for sure and efficiencies, but that we're all individual people. And somehow there needs to be a reconciliation between those tensions of individual preferences and healthcare efficiencies. It is a tension.
Yeah, I like to call it, we are trying to have standardized customization. We actually want to standardize the idea that we can customize care.
Yeah.
Yeah.
Mm.
Yeah.
If it's okay, maybe we can change gears a little. Amy, you are a patient and public advisor for Choosing Wisely Canada. Can you tell us all a little bit more about that?
That's the $1,000,000 question that people are trying to crack. And with Choosing Wisely Canada, it's this Time to Talk. It's Time to Talk campaign. And we try to produce material that the layperson can understand, and also to work with the different societies like oncology, cardiology, and family doctors to see who has time. But there's multiple moving parts. You're absolutely right. What I hear repeatedly is that when people are not informed, they get a lot of unnecessary, highly interventionist care right at the very end, and it doesn't improve your outcome at all. But it's probably devastating to have all of this aggressive treatment thrown at you, and for the family to witness this, and no one's told them, wait a minute, what you're experiencing now, is it just a local minimum, or is it part of a larger trend that you cannot fight no matter what?
Yeah. And when you say, who's got the time, to have these conversations, I guess I challenge the healthcare providers to think about beginning these conversations as early as possible. We know when people are diagnosed with certain illnesses that from the get-go, they are progressive in nature. These are not chronic illnesses. They change over time. They have hills and valleys, twists and turns. The landscape changes, and requires a nimbleness and a flexibility. But with those kind of changes on the horizon, it is important for us to begin those conversations early so that it never derails a clinic. And it's not like everyone's scrambling for the time to have the one conversation. It's about inviting these open, honest, realistic conversations from the get-go so that everyone shares in the responsibility of making sure that people have honest medicine.
I like how you say that it's a shared responsibility, Sammy. We want to get to where it's shared, and there isn't a whole bunch of people saying, no, it should be the family doctor, and someone else saying, no, it should be the chaplain, and someone else saying, no, it should have been the oncologist.
Yeah.
It should be all of them.
Yeah, totally.
Elise?
Yeah, I was just going to pick up on something you said earlier, Sammy, about learning and literacy. And it's actually why you have this podcast, is to educate the public a certain amount about this. And that's something that's very dear to my heart, because I think with the way medicine is going now, and with it becoming more personalized and so on in the future, I'm a digital health fanatic here, if you will. All of those changes are going to be requiring us to understand more and more about our health so we can make more and more informed decisions. Mm-hmm. So where does that happen? Mm-hmm. How does that happen? Your podcast is wonderful, but we need to know so much more. And I would love to see, better education from the kindergarten curriculum on up. Mm-hmm. It should be part of it, and including the conversations about death. I think that children, I remember when my boys were, I think, 10, they got sex ed at school, and they came home, their homework was to talk to me about rape. Well, hello, why can't we do homework to talk about death with your family? I think
not the same night.
No, I would say not. No, but I think we're remiss that we don't do that. We don't prepare people for actual living. I mean, 100 years ago and so on, people were faced with it because it happened all around them. We're anesthetized from it because it doesn't happen all around us. Mm-hmm. And so we're not good at it.
Mm-hmm. I'm hoping that we can encourage people to start asking questions about, well, what if I don't? And what if I say no? And what if? clinicians have a much easier time talking about what they think is the active option, like doing the test or having more medication or doing treatment. They're not as comfortable talking about what they're comparing that to, which is do nothing. What's the natural history of my condition if I don't choose that? And so we really cannot present options to people just with covering the pros and cons of the treatment or the test. We really need to help people understand what they're comparing it to, which is if I do nothing. And,
Yeah, but the reality is we're not really doing nothing. What you're actually offering is information.
well,
And
yes, that's a good
information,
point.
yeah, but information about the big picture, which is hidden,
Yeah,
that information can become power if you know how to use it, if you understand where you are, and then you can make choices. So it's not really doing nothing. It's giving information so that they can be informed about the choices that they can make. And as you've said, when you provide information, that can also
yeah,
manage symptoms and make people feel less distressed and anxious and have all these other
yeah.
positive
Good,
effects. Yeah.
But I
good point.
wonder how many doctors are trained to actually give the option of, and this is what will happen if we just take a wait and see approach instead of, I guess, with all the skills and all the tools that you've learned in medical school, you're just itching to use it instead of letting nature take its course and give that as an option. Well, if we don't do anything for the next 3 days or 5 days or 2 weeks, A, B, C, D will happen,
Yeah. Yeah. There's definitely an incentive and a push for newer technologies, fancier drugs, the bigger machines instead of the art of medicine, which is to listen. That's the thing about the time to talk. There's also the time to listen, at least for the provider side. That's part of what we're missing is the watching and the listening and the picking up on all that intel, around us, around the patient, not just the disease, but how is the family coping? And are they walking a bit slower? And, what are they not saying that actually they should be talking about at this stage? And that's a clue. That's a big thing that we should be bringing up.
I've only ever cared for people in their home. That's not true. Of course, I trained in acute care, but I have practice in people's homes. I've trained in clinics, I've trained in hospice as well, but 100% of my practice is in people's homes. And I have learned very quickly how to work with families and caregivers. And I wonder if some of the problem that we're talking about is because we train doctors almost solely in acute care settings and, maybe clinics, that they really don't have to ever learn in a meaningful way how to work directly with families. I have to in the home setting because those families are my first responders. Those families are our doctors and nurses and OTs and PTs and dietitians and pharmacists and PSWs and everything else in people's homes. I could come up with what I think is a reasonable plan, a care plan for the patient. It will only ever be as good as it's been negotiated with the family and it's acceptable to the family and that they can implement it. It's a non-starter. The way I speak in people's homes, the way I dress, the way I act, the power differential between me as a doctor and the families that I work with in their home is flattened.
Well, you're meeting them on their terms. You're meeting them on their terms in their territory, and that is what makes all the difference. Donald Lepp, he's written a book about his child's journey to get a heart transplant as an infant, and he talks about going into the hospital as though you landed on a different planet, different language, different culture, completely foreign to everyday ordinary life.
And my point being that if we do not train doctors in the care setting of the community and in people's homes, we're really behind the 8 ball. It's not mandatory to teach doctors how to care for people in their home, but we're expecting them to work closely in partnership with families. So something has to change with the curriculum. And so when you guys are sitting as patient and family partners, wherever you're sitting, please reinforce that message.
Well, the funny thing is, I think the digital health movement is actually moving things back to the home with wearables and remote monitoring. And you're going to fail miserably if you think you're just throwing a whole bunch of technology and expecting the person to figure out this gadget plugs in there and I have to be in front of my Wi-Fi at such and such a time to give you the feedback without bridging the gap and building a relationship.
But, the other thing is, sorry, I know, Elise, you want to say something. I just wanted to mention that, with virtual care, and people now zooming into people's homes, and that's happening more often. I think there's lots of potential, and I think it's wonderful to, again, bring healthcare providers into people's homes. But in the absence of a curriculum that teaches doctors, I'll just focus on, how to care for people in their home, it is a little bit scary to now provide virtual when they have no idea what this care setting is really like. They don't understand that virtual care is really care with, not blinders, what are these called? Like you have the peripheral vision.
Blinkers.
Blinkers. So, I think maybe we can leverage virtual care as a reason why we have to train clinicians to know what it's like to work in people's homes with patients, with families, with visiting nurses in their own environment. And then you can do virtual care in their home, but we can't leapfrog over the training. Okay, Elise?
Yeah, so this is very dear to my heart because I think you're absolutely right. We need to train physicians for sure, and probably nurses and so on. They tend to have to deal with caregivers and families as well. But I was thinking about in the training of doctors, I think there's a couple of things that I'm hearing in our conversation. One that strikes me is when you present treatment options, one of them should be the what if we don't do any treatment option? And I think that should always be on the table. And so how do you handle that? What do you say? If the treatment is A or B or nothing, always it should be A, B, or nothing. And how do you deal with that? And how do you talk about that? That's one element. And then the other element, as I mentioned earlier about the digital health, that's going to upend healthcare and is already doing so, as we've seen with the virtual care. But that takes a certain talent. Right now, the virtual care I'm getting from my primary care doctor is by phone, and it tends to be less of a back and forth than I would wish, and certainly less of a back and forth than in person. So there's some training that needs to be done there, and it's going to mean we'll have a very bumpy transition as we go through, having to maybe retrain people who are already physicians and then building this into the curriculum. But the patient partners, we can help because we can become part of that curriculum as well, and help people understand what it is to be in a home with patients and caregivers in a sort of an academic environment, so that when they actually go into an environment like that, they're not wet behind the ears.
Yeah, like simulated lab.
Exactly.
You're in the living room and here's the hospital bed in the dining room.
Exactly. So, or right now I have a sister-in-law who is an actor, and she does a lot of work with what are they called? Standardized patients for training of doctors. Well, we should also have standardized caregivers, so the script is more encompassing. In fact, I might just speak to her about standardized caregivers.
I think it's a great idea. It's a brilliant idea for sure. I wanted to ask, as you know, our mission was to target patients and families directly, because we felt like this was information that we have decoded that they deserve. And I guess from your perspectives as patient partners on research projects at tables, at healthcare systems and hospitals, trying to change the culture there, do you think we're onto something? Like, do you think we're going to be successful at making a wave and making a change if we can empower patients and families to ask the right questions and to know that they can invite themselves and to create this revolution? Or do you think that we need to, rethink some of this?
Personally, I think it needs to be coupled with the education we've just been talking with, because if we have two halves of the equation. One half is the patients and families, which this webinar is addressing, and the other half is the professional community. If they're not changing in sync, there's going to be a bit of a difficult adjustment.
Yeah, we've talked about that actually. Here we are setting a fire under the citizens of the world, and they're going to rush the healthcare system like new activated superheroes in their own healthcare journey. And they're going to be met, and they're going to ask big questions like, doctor, I would like to know what the natural history of my illness is. I want to know the big picture. I want to look long. I want to know what's ahead of me and the twists and turns. And I'd like to know my prognosis. And thousands of people will come to the healthcare system and be met with doctors and nurses who still don't have the training and the comfort to answer those questions, and will be stopped in their tracks. So we agree that simultaneously we need to, and there's lots of work being done trying to help doctors and nurses. We shouldn't pretend that there's no work being done. There is lots of, but it's just not happening fast enough for patients who really need it to make truly informed decisions. Throw MAID in there, the legalization in Canada. And it's very scary without making a personal judgment about MAID. It's very scary to think that people will be making a life and death decision potentially with not all the information about their health. So it's critical.
Yeah, it's critical, but then medicine is a very conservative culture that changes slowly. I heard that even just for the stethoscope, it took over 30 years before the uptake was generalized.
Really?
And it is necessarily the case that right now, the way we're going to look at research for pick your vulnerable or marginalized population of choice, that even the research ethics has to change. I heard a presentation about somewhere out in Alberta where they wanted to mobilize the meat packing plant employees. And they had to jump through many hoops with the ethics board of the university to say that having the people in the plant to do the survey was better than having some anonymous person behind an email that was the requirement of how you do conventional studies, because it takes a lot to build trust already, and they were going to ignore a random stranger that they had never heard of, even though that random stranger was approved and vetted by the university. They had to build in flexibility. It's a global pandemic. People are dying. So that's one aspect. And then the technological aspect of, by the time you get the research project approved, you've gone through alpha, beta, whatever testing for a wearable. And how is that going to meet the rigors of what the patient needs, what the doctor needs, if we're just stuck with the traditional old model that was never built to accommodate the fast pace of cell phone models changing that are expecting to be replaced every 2-3 years.
Yeah, that's one of my pet concerns also, is the cycle for research. I mean, some of it will naturally have to be longer, but what have I heard? It's over 7 years between start to finish. And we need research much faster than that. So there does need to be big changes even in the research community. I would love to see at least at the provincial level, one research ethics board, for instance, and the data sharing agreements that people have to do. All of these things are such incredible impediments to having a fast enough turnaround to the research that we badly need, especially with COVID lurking around. I think we're starting to understand that, but it needs to be addressed.
Mhm.
Yeah, I couldn't agree more in all aspects. And it's hard to find. I really think about my research of how it can be adaptable and flexible from the start, and even if it takes 5 years, like what will this still be relevant then? And of course but you're absolutely right. But we often like to end our interviews with, what advice do you have for other patients or families who are starting a journey that you've learned from your experience?
Well,
Never go alone. Never go alone. Always bring someone with you.
Yeah, very good point. Very good point. I think from my position, it is, face the truth square on, get the knowledge that you can, because knowledge is power. And without the knowledge, you could be making decisions, as you all know, that are not optimal for your situation. And it puts you in a place of fear. And who wants to live there?
Mhm. Mhm. And fear amplifies symptoms and suffering. And
Mhm.
then you know what? People get more morphine. When really what they needed was more information.
Wow.
Yes, I'll take info over morphine any day.
Wow.
Thank you both so much for joining us. I
Mhm.
really appreciated all your time. I loved our conversation, your
Well,
stories.
this was fun. Thank you.
So thanks for having me. It's been absolutely wonderful, this conversation.
Thanks for listening. Please visit our website, waitingroomrevolution.com, to listen to our first season about the 7 Keys and to learn more. The podcast is produced and edited by me and Kayla McMillan. Our theme music is Maybee by Ketsa. Please rate, review, and subscribe to our podcast and help us get the word out.